So thanks so much for joining us today. My name is Dr. Sean Whatley, and I'm the president of the Ontario Medical Association. I'm here today on behalf of 40,000 physicians who see 320,000 patients every single day in Ontario. And I'm here to make sure that healthcare is made a priority for every single MPP and each political party leading up to the election in June. For healthcare in Ontario, this is perhaps the most important election in a generation. There is no time for delay or mistake. The next government will have to deal with the urgent problems our patients face every day. Many patients in Ontario are facing unacceptably long wait times for access to tests, specialists, and treatment. For example, more than 12,000 children and youth are waiting up to 18 months for mental health care services. Some patients wait up to 6 days for an acute care bed, a mental health bed in an acute care hospital. And those days are spent in the emergency department. Noisy, no privacy, no peace. According to Health Quality Ontario, the current wait time for long-term care beds in Ontario is 149 days. In some communities, such as Ottawa, the wait is up to 2.5 years. If we look to the north, many patients in Northern Ontario must travel to larger cities for care. For example, folks in Kenora have to travel to Toronto to see specialists. It's easily a 24-hour drive. Our population is aging. By 2041, 1 in 4 Ontarians will be over the age of 65. This means we must fix our system now. Government simply doesn't have an option to not work with those of us on the front lines of care, those of us who see what patients need every single day. We must work together to find real, tangible solutions to these problems. As I mentioned, Ontario doctors treat 320,000 patients every single day. We operate with scarce resources in a broken healthcare system, and yet we continue to make a positive difference in the lives of our patients by providing high quality care. You know, our great province is fortunate to have outstanding doctors, nurses, and healthcare providers. Ontario doctors want to make a concrete change. We spend every single day trying to provide high quality care, and we need to have a working relationship to make that happen. So the problem is not the care that we have, it's the care that we have to wait for, and that's why I'm here today. I'm bringing these concerns to each and every MPP with our priorities document. We have them individualized for each MPP. We want to show how important it is that these issues are addressed by the government, working with Ontario's doctors to improve healthcare in our province. Thanks so much for being here today, and I'd be happy to take questions.
Has anything progressed in your contract negotiations with the province at this point? Because it's going on 4, 5, 6 years now?
Yeah, so we've been 4 years without a contract, and we're now in a binding arbitration phase. But I think the important message in this is that the contract provides a platform within which we can solve patient care problems. So unless you have a working relationship between management and labor, you can't solve all the nitty-gritty problems that come up. And that's why, partly why, we're seeing the problems that I mentioned here today.
The last that I'd heard about this was that there was about a $10 billion difference between the OMA and the province. And I know that the Premier just made an announcement of more hospital funding and whatnot, but it's nowhere near that $10 billion difference. So how do you begin to make up that difference or find compromises?
So the number that you quoted was published by a media outlet that we don't actually agree with that number. So there certainly is a gap. We think that we need fundamental work done, starting with the relationship. Once we have the relationship together, a working relationship based on equity and respect, we can start hammering out practical solutions that are going to make a difference to patient care. So we've been 10 years with sub-inflationary increases in hospitals. We've been 6 years with cuts to the physician services budget. It's going to take more than a Band-Aid at this point in the game to improve the quality, access, timeliness of care that our patients receive.
What is the gap? How big is the gap? If it's not 10 billion, how big is it, Doctor?
Well, that's one of the primary issues that are in dispute right now before the Board of Arbitration. So as you know, we're going to arbitration May 24th and 25th. I believe it's 24th and 25th, or 23rd, 24th. And that's one of the main things that are in dispute right now, the size of the physician services budget. But our platform is much more beyond our contract negotiations. If you read through the document, happy to give you a copy, we're focusing on wait times across the province. So we talk about code gridlock, the fact that we have 12,000 children and youth waiting for mental health services over 18 months. In my community, we don't even have certain specialty services. So we need to solve those issues. Definitely, we need a contract, we need a working relationship, but the problems in the healthcare system go way beyond simply what needs to happen for doctors.
It sounds like you had a sympathetic ear from Patrick Brown and the PCs, but he's gone. So what have you heard from Doug Ford?
Well, we're reaching out.
Or have you talked yet?
We've asked for a meeting. We haven't had an official meeting yet. Our staff members are speaking with members of all parties. And so our platform is focused on whoever forms government. I think no matter what their history is with respect to healthcare, whoever forms government in June must focus on healthcare. And we're hoping that healthcare will be, if not the priority in this election, at least one of the top priorities.
Isn't healthcare always the top priority? I mean, we've seen the Premier spend every day the past week. There's been another announcement targeting different sectors of this. So to have someone from the OMA come up and say, this election we're really hoping that healthcare will be included, seems on the surface to be sort of silly, because isn't it always the top priority for the government? It's the largest chunk of spending they do, after all.
Well, I would hope that would be the case. If you, like you said, the spending is almost 50% of the budget. You'd think that this would be a major policy platform for each party. You'd think that this would take up most of the time in debates. You think that this would be the topic of conversation with the media. It's not. It's not. And yet we have problems piling up year after year that must be addressed. I mean, even we've been talking about the aging population for decades now. Kai just put out recently that this is actually really going to hit us now in the next 15 years, possibly 20 years max. We must have a commitment from government to at least make this a priority. And it's not simply about funding. It's about working together with frontline providers, the doctors, nurses, and other healthcare providers, to find concrete solutions to the problems we're facing.
How does increasing the physicians' services budget reduce wait times? Because from what I understand, the government has been trying to drive efficiencies in the system and getting doctors to do more procedures. So I think what the government's trying for is more procedures, like get more volume in. So if you just pay doctors more, won't they have to, they won't have to work as hard to make as much money, and then there could be fewer services. Isn't that what the government negotiators are arguing?
So great question. And what you're raising is the issue that this isn't a one-to-one relationship where I simply pay you more and therefore we have more of Y. It's multifactorial. You have to look at operating room times, you have to look at support. If you look at hospitals that don't have, that are operating at over 100% capacity, that means you have beds that don't have nurses assigned to them, and yet the nurses are trying to care for them. You need all of that working to be able to deal with wait times. When it comes to physician remuneration, we need to keep Ontario attractive so that we can draw top talent to Ontario to care for our sickest patients. I'll give you a concrete example. In my community, I'm just north of Toronto, we have a catchment area of about 1 million. Our emergency department is the third largest in Ontario. We had one vascular surgeon for years. We were begging to get another vascular surgeon in. Well, that vascular surgeon has many opportunities to look, not just in Ontario, but across Canada and indeed across North America. They see our sickest patients. And when I call a vascular surgeon at 3 o'clock in the morning for someone who has a rupturing artery in their abdomen, I need them there in about 20 minutes or that patient dies. So you can't ignore the fact that doctors have been cut for the last 6 years in our ability to recruit and retain top talent, especially for the care that our most vulnerable patients need. But you're absolutely right, it's not only about that, it's also about how the whole how the whole system functions.
That's what I was getting at. So what kind of remuneration are you looking for, are you hoping for out of this arbitration increases for doctors?
So our arbitration positions are
Already, so I'm just trying to figure out how that goes.
Sorry, I cut you off a bit there.
Yeah.
So our arbitration positions are public, as are the government's positions. And right at the start, in the first round of arbitration, when we present to the Board of Arbitration, we're discussing the cuts that have happened so far, normative fee increases, and we're asking for what every other public sector worker has had, and then the size of the physician services budget. These are really fundamental issues that need to be hammered out. And until you can hammer out those fundamental issues, you can't even start talking about the specifics that you're addressing. So there'll be 2 phases of arbitration. First phase, we'll look at the macro items, and then into the fall, we'll look at the micro items. I appreciate your questions on the negotiations and arbitration. I could talk about it all day, but our issue here for today is really a multi-stakeholder approach to saying, please, members of provincial parliament, make healthcare a priority. We had a massive stakeholder breakfast this morning at the OMA. Many other stakeholders in the system are concerned about this too. Although it's a big budget item, it doesn't seem to get the policy attention that we'd like to see it have. And we think now is a crucial time. This is a change in a generation, I think, this election coming up in June.
Do you think with this election, like, are you disappointed that Patrick Brown is gone? Had you been hoping that the Liberals would be gone and you would have a different, maybe perhaps better luck with a Brown government in place?
Well, first of all, Ontario Medical Association is nonpartisan, and we have to work.
One of Brown's guys, Whatley Solomon, was working for you guys, so.
Sorry, who?
I know one of Brown's campaign people was also working behind the scenes with you, was he not, Whatley Solomon?
I don't know that name, but yeah, if you can tell me where they work, maybe afterwards. What we've realized over the last 3 or 4 decades as at the OMA is that we have to be able to work with whoever forms government. And so it's not in our best interest, it's not in patients' best interest, it's not in the best interest of healthcare in Ontario for us to be ultra partisan and to attack any party. We need to be able to work with every single party. And so we've reached out to every single member of provincial parliament. I've met with each of the leaders of the parties, and with respect to us being more vocal on the problems in the system. So when I had a meeting last August with Premier Wynne and then Minister of Health Hoskins, I said to them very clearly, I said, I want to let you know that our members and patients expect us to be much more vocal, much more open, much more honest about the problems in the healthcare system. So in the same way that if you were my patient and I saw a spot on your chest x-ray, you'd want me to tell you the truth about it. But not to say it in a nasty way, to say it in a solutions-based way, a kind way. This is a problem. These are some options. Let's work it out together, and we're going to stick with it until we actually find concrete solutions. And the Premier said, I would expect that of you. She said, absolutely. So it's been, 8-9 months before we actually get this work going, but that's what we're up to this spring. We want to be honest about the challenges within our system, and it's going to require a multi-stakeholder working arrangement to actually be able to drive change.
Just one last one, if Andrew doesn't mind, or Hughes doesn't mind. I thought I heard a radio ad on this morning. Have you guys started a new ad campaign, or
We do, yeah.
Or have I been missing it for the last few weeks?
No, I was hoping you said you'd heard it a dozen times already.
I don't drive very much anymore, so.
Right. Yeah, no, it's called Not a Second Longer.
Yeah.
And again, this speaks to what I mentioned to the Premier in August, that we believe wait times are a crucial issue to address in being able to deliver quality care in an accessible fashion. And we think that addressing wait times is certainly a key issue in getting this conversation started. So yes, we have radio, print, we have some digital ads as well.
In the past, the government has pointed to the OMA contract as part of the problem when they come to reforming the system. I think an example is when they say they'll pay one profession, one type of doctor, more than they might have in the past, whereas they don't have enough to really attract doctors who work in, say, the mental health field. I think that was one example. How flexible is the OMA in terms of moving money around within the envelope to ensure that that they have funding to attract the doctors where they're needed?
So you kind of have a double barrel question in there, and I'll try to answer them both. First of all, you said, is the contract really an issue in...
No, in the past.
In the
I know
past,
there's not
absolutely.
one right now.
Absolutely.
No, in
No.
the past.
And that's a brilliant question to ask, and I would say absolutely. So I've said to many people, they talk about the contract negotiations as being about money. It's actually more about solving patient services. For example, access to mental health services. And so unless you have that working relationship where we can say, this is what we need to emphasize, we don't have people that can access care in a rural community with mental health problems and diabetes. Well, that's because we have no funding directed to that. So those sort of questions get hammered out at the physician services agreement level or at the physician services committee. So the contract plays a huge role in how services are delivered in Ontario. And that's why it's so crucial that we have it. 4 years with no contract is just, it's egregious. You can't expect a high functioning system when you have no contract, no platform for discussion between labor and management, if I may refer to us as labor and management. Your second question was about what control do we have for moving around money?
What resistance do you have?
And what resistance too? So a third question. So the second question is, what control do we have? Traditionally, very little. That was determined at the negotiating table, and up until now, it's been very unbalanced with respect to power in favor of the government side. So at the end of the day, if the government said, no, this is the contract you're getting, then that's the contract we're getting. And we had to try to work within that and try to still maintain relationship, because we knew that the government always had the power to impose what they want. That whole paradigm has changed with binding interest arbitration. So now we can continue to advocate for example, let's say we think it's important to be able to do what you're suggesting, then we would argue that in front of the Board of Arbitration. So we'll see if the ability to adjust funds within a physician services agreement is something that comes out of this contract. I don't know. Your third question was, and I forget it, was it about resistance or? Yes?
Well, it flows out of all of that, but yeah,
Yes.
the OMA's resistance to having, for instance, money in one specialty, perhaps shift. You want overall more money, don't you?
You're talking about relativity.
Yes.
Yeah.
Yeah, so I was hoping he wouldn't remember the term for it. So relativity is a huge, huge topic. They say that fee relativity has been a challenge for physicians since the time they started accepting fees. And so forever. Now, what we do know is other jurisdictions do it better than we do, and there's always an opportunity to improve that. But we're not even at that level of discussion when it comes to our contract discussions at the Board of Arbitration. So that would be into the micro issues. We're still talking about the 3 macro issues. That'll take us through to October, and then we'll have to start addressing those kind of questions into the fall. But again, I love your questions on the contract. I appreciate that you're asking about it. But really the key for us here today is to make sure that every single MPP makes healthcare a priority in their work and in their election this spring. We have individualized platforms that we're going to give to each MPP. So for example, this one's to Kathleen Wynne. Did you know that patients in your riding are waiting 232 days for cataract surgery? And we'll have the same individualized handout for each person in the riding. So I really appreciate the questions about the contract. I believe it's critically important. But our message here today is that healthcare is bigger than even that.
Okay, one last one.
Okay.
Dr. Whatley, so there's arbitration dates May and then again in October, is it?
I believe May, June, July, and then October, but we can get to you the exact dates if you want them.
So is October the end of it, and then the arbitrator noodles everything and when do you expect a decision?
So great question, and people ask this all the time. Two ways to answer it. Number one, this is the first time we've ever had a physician services agreement arbitrated in the history of Medicare. So this has never happened in Ontario before. So no one can say for certain, even to make a prediction on when it will happen. What we can tell you is we have dates booked for the Board of Arbitration. If for some reason they do their work much more quickly and the arguments are crisp on both sides and the solutions are obvious, maybe they'll be done early. Maybe they only have to meet for 2 days. I would be shocked if that happens. Once we have a change of government, how will that change the tone at the arbitration table? We don't know how that's going to happen. What we are confident is that now that we have a neutral third party adjudicating our differences, we at least can hope for some solution at the end of the process. The experts tell me that it's not uncommon for large labor contracts to run 18 months during arbitration. That wouldn't be unusual. When you look at this as what I've heard to be the largest labor contract in North America, I would expect that it's going to take a lot of time. This is like a major court case, right? Both sides have to prepare briefs. They present to the three-member Board of Arbitration, and then they start hammering out how best to solve these problems.
So we might not know by the end of the year, but we might.
Well, certainly by the fall, I hope the macro issues will be decided. And that's really the big things that need to be worked out. Then you start working into the micro issues. But I hope you're as excited about our platform as we are.
I'll read it and see what I can do.
All right, excellent. Thank you very much. I really appreciate that. Bye.